You have any questions for us or any last words before we end the call?
We'd be very happy to come back in a month and show you the updated results if this carries on. I just really hope it carries on.
So, as Dr. Corey and myself, who really at the front line, who treat these people every day, who get hundreds of emails from people around the country questioning why they can't get ivermectin. So, our plea would be, while we're waiting for definitive data, we think there's sufficient evidence now for the NIH to change the wording of the recommendation. The reality is that physicians just will not prescribe it because it seems like the NIH is discouraging them from prescribing it. And there are hundreds of thousands of people out there who are really angry because they want to get ivermectin and they cannot get ivermectin. So, we'll obviously, leave the evaluation up to the NIH, but, our plea would be, people are dying now. People would like access to this. And the current wording is such that doctors just do not want to prescribe it. Pierre, would you agree with me?
Yeah, I would. And I would just add two things, which is, you asked if we had a question. One of the things that we are going to, and I know as a committee.
I think you're muted.
Oh, sorry. Yeah, I did want to add one thing, which is, one of the things that we see, out here on the front lines is, we make a lot of decisions clinically. I mean, listen, I know we all want A1 evidence before we make a decision so that we could remove any possibility of getting anything wrong. And we want bigger trial. We want all of that. But on a safe drug, on a risk-benefit analysis in a pandemic with hospitals filling and case counts is skyrocketing on a safe drug, I mean, we're sort of hoping is that if there's any precedent for a risk-benefit analysis judgment in a pandemic. That would be one. And then my last question is just, I can't figure out, can anyone tell me why there's an A3 against such a safe medicine when, many of the other therapeutics that are being used seem to have gotten like a neutral, cannot argue for or against, but this one has an A3 against, and so it seems unique, and I was wondering why.
Well, the recommendation is actually against except in the clinical trial, and with obviously the understanding that there are not that many clinical trials in the U.S.
Well, that's another issue, but I wanted to know why that got this, why ivermectin got this one when none of the others did. I guess it's unclear. Yeah. So anyway, we just wanted to, we were hoping, yeah.
We should address this. I mean, I think that was basically the judgment of the team looking at the available data at the time. I think, as you noted, that recommendation hasn't been updated since August. We're looking at the data now to see, indeed, as you indicate, whether or not a change in that recommendation would be indicated. I think the feeling was then that they didn't see a mechanism. The antiviral property was felt to be challenging given the PK. You've given some explanations as to why you think that's the case. And that was basically the judgment of the group at that time based on what they had to look at that time. But I think anytime you see a 3 from at least this guidelines panel, I think it's fair to accept that they just haven't seen enough data to really have a well-informed opinion. So all they can provide is an expert opinion. I had one question to follow up with. Do you know if there's any effort by any of the companies that make ivermectin to try to get emergency use authorization in the U.S. or similar qualification elsewhere?
I know that they've been trying since, I know Edenbridge Pharma, which produces or apparently supplies 99% of the U.S. Consumption of ivermectin. I think they've been approaching multiple agencies since the beginning, but again, the clinical data early on was not there, and I think they're hoping to hear from, the more data that we can provide and Dr. Hill's team can provide, maybe that'll happen. I don't know. I mean, it's already FDA approved. It would just, we do non-FDA, off-label prescribing all the time. It would be nice to get an EUA, but I don't know that it's critical, but that's a little bit outside of my element.
And just to add to what Dr. Lane said, a 3 recommendation expert opinion is the one that we generally are least comfortable with. that means that the information that we have is not as good as we'd like it to be, which is one of the reasons why we invited you here today, to really show us what is out there, what you're thinking, and give us some more information to really critically look at to see if the recommendation should stand or should be modified based on newer information.
Okay, fair enough.
Thank you for coming, and we will be in touch if you want to share with us other data in the future as well.
We will.
Thank you.
Thank you.
Thank you for having us. Appreciate the invitation.
Thanks for inviting.